Hanif. Dr. Wasim Hanif will speak on how to achieve and recruit global representative population in diabetes research. To say Dr. Hanif is a professor of diabetes and endocrine, head of service in diabetes at University Hospital, Birmingham. He is an honorary professor of medicine at University of Warwick and visiting professor at Birmingham City University. He is the board member of Center for Diabetes Endocrine Metabolism, University of Birmingham, and Clinical Advisory Group lead for research in diabetes and endocrinology at Institute of Translation Medicine, Birmingham. He is recipient of several national and international awards, if we include prestigious South Asian Health Foundation UK Lifetime Achievement Award, being eminent authority in the field of diabetes, obesity, and ethnic health. He has worked on several national bodies with professional groups. He is well-known authority on real-world evidence, working on the big data with a dedicated bioinformatics team. He is involved as a chief and principal investigator in several international multi-center trial and was instrumental in setting up UKPDS, which we all follows. Professor Hanif has been involved as a parliamentary level to advise government on issues relating to diabetes and ethnic health. He is on the board of governor as a trustee of Diabetes UK. He is a chair of Diabetes Working Group of well-recognized South Asian Health Foundation. He is a member of European Policy Forum on Diabetes advising EU. His involvement in NICE has been extensive, sitting on advisory NICE Health Technology Appraisal Committee between 2009 to 2015. He is involved on several international projects, which includes IDF, WHO Global Policy Forum on Diabetes, Strategy on Commonwealth to guide the minister on at UN Summit, Chair International Advisory Board for ORNET Project India of MRC and member of UK Foreign and Commonwealth Office Scientific Trade Delegation, among others. So it's really an honor to welcome you, Professor Hanif, on this dais. Please, the dais is of you, sir. Thank you.
Thank you, Dr. Panchal, for your kind words. I'll probably just try and share my screen. I have got a meeting, so I will probably be leaving after my talk. So if there are any questions, I'll be happy to take them. First of all, I would like to take this opportunity to thank the DiaCare committee, including my good friend, Dr. Banshi Sabu, for the kind invite, among the other members as well. Now, what I'm going to be talking today is slightly a different field to what we normally talk on this on these conferences. But I think this is a very important issue. And in my various roles, I have started realizing that if we actually look at the population in whom the research is done in diabetes, is very different from the population that we are treating. Now, in my talk today, I'm going to take you through what the issues are, show you a good case and a not so good case, and then make some recommendations. So this is a very interesting, what you can call a heat map about the world total population. As we know that the bulk of the human population either resides in the Indian subcontinent or in China. That's where nearly half or more than half of the global population is. Now, if you look at the prevalence of people with diabetes, and again, as we know, diabetes is turning out to be more of a kind of an Asian pandemic, starting from Horn of Africa to the Southeast Asia. That is where most people with diabetes live. And if you look at the prevalence rates in the UK, currently we're talking about 5%, while in countries like India, we are really getting nearly to the 20% mark. And with these big populations, we need a better understanding of diabetes. Now, if you look at the world by the cohort of publications on diabetes that comes in, what you find is that the most of the research in terms of large landmark clinical trials that really shape our practice, shape our guidelines, the reasons why we do either you do the ADASD guidelines or the cardiovascular outcome trials. Most of these publications have either come from North America or Europe. So this is something which is a very important issue for us to acknowledge and see how we can tackle them. Now, this is a review paper that we did a few years ago with my good friend Professor Kunti. And what we basically looked at is 12 studies which really shaped the ADASD guidelines in terms of the cardiovascular outcomes with glucose-lowering therapies and type 2 diabetes. And what we found was, if you look at the South Asian population, where most of these studies or medications will be used, we're underrepresented in trials compared to a global population. So these trials did not have a representative South Asian populations. And then we actually concluded is that the clinicians should exercise caution when generalizing the results of trials to their own practice. And this is something very important. Now, let us focus on what we call health inequalities and what they are, and see how we can deal with them. So health inequalities, I think this is probably the best definition I could find of the health inequalities. These are avoidable inequalities that are unfair or unjust. In the UK, we have got something called the Equality Act of 2010. And this basically tries to handle the issue around health inequalities in the NHS. And it lists about 8 conditions in which people could be discriminated, and efforts should be made for them not to be. So this includes like race and ethnicity, religion, age, etc., etc. So why is research important? And I think this is something very important. So this is a publication from NIHR CRN. And what it basically shows is research in a hospital setting, and this could also be true in a population setting. So in centers that do research or involved in research, the mortality rate is extremely low. So if you're high on research, the mortality is low. And in centers in which the research is low, the mortality is high. A very simple association showing the relationship between the research and quality of care. And this can not only be applied to the institutes, but can be applied to the populations as well. So in populations or in groups in which we do less research, we are going to get high mortality or poorer outcomes. And in communities in which more research is done, you're going to get lower mortality and better outcomes. So research is not an optional extra as a health practitioner, but it should be an integral part of the practice. So the NIHR CRN have come up with these things that research is very important, and NHS does a lot of research, and it cares for nearly 1 million patients every 36 hours. But even in this situation where research is a part of a healthcare system, certain communities are underrepresented in all studies, and this includes ethnic minorities like Black and South Asians in the UK, women, and elderly. Now, I'm going to start off by saying, so whenever you talk about doing research in ethnic minorities or in South Asian communities in the UK, one of the things that is mentioned is that these communities are not interested in taking part in research, or they don't have the aptitude for research. Now, let me rest that myth to a while. So this is one of the studies that we set it up about 20 years ago. This is the United Kingdom Asian Diabetes study. And the principle was very simple. In Birmingham, we've got a big South Asian population, and we wanted to see what is the effect of diabetes or improving diabetes care in this population. I'm not going to go into this, but this is some of the publications that came out. Still, it is one of the longest running cohort of patients. And some of the early studies or findings that we have from this study showed a clear differentiation between a South Asian and white population in terms of their profiles, age of diagnosis, duration of diabetes, ethnic difference in HbA1c, which is maintained over a 20-year cohort, more deaths in South Asians when compared to the white population, and a much higher prevalence of diabetes. We have also been doing a lot of work on Ramadan and diabetes, which is quite, again, a specific area and something very difficult to do in the UK setting. Since then, a lot of studies have been done at a global level. This is just to show you the hierarchy of evidence, as we all know. Now, sadly, the studies that are done in an ethnic minority population, and I'm going to use the example of Ramadan, are actually a bit low quality studies. So this is an update I presented at the South Asian Health Foundation conference. And we did a kind of a Medline search on Google Scholar, and we found nearly 230 publications on Ramadan. This was in 2021 and 2022. But the problem was there was increased number of studies, which is good, but these were mainly observational studies of low quality with very small sample sizes. And most of them were guidelines and consensus statements made on these small sample size. There were no RCTs or good quality RCTs. And there were very few mechanistic or lab-based studies. We've tried to address this by doing more of what we call real-world studies on validated databases. This was one of our studies led by Maria, one of our research fellows, and Krish. And this, we actually looked at the THIN database, which is one of the largest validated database of nearly 12 million people, over a period of 10 years to find the rate of infections in Ramadan. So one of the challenges, as I'm going to be talking about later, is that if you're interested in doing studies in the population, you can develop a methodology that is not just based on funding, but by on other means to address that. Now let me turn to another issue, and just to illustrate why is research important in all populations. Now, one of the landmark studies that has been published from the UK by two very good colleagues of ours, Roy Taylor and Mike Lean, has been direct studies. I've seen direct being talked about globally, and I've attended a lot of conferences, virtual ones, in India, where direct has been said that this is a study for remission of diabetes. And it's absolutely brilliant studies, which was done in a primary care setting in Scotland and Northern England. It had nearly 149 practices, looked at total diet replacement, and it had some amazing results. 50% of the population achieved diabetes remission. So depending upon the weight loss, if you lost 15 kilograms in weight, then 86% of patients, the diabetes disappeared or went into remission. So excellent study. And there was been a lot of excitement, both in the UK and globally, to translate this study. But this study had one issue, just one issue. And this was nearly 99.9% of the population in this study was white European. And most of the population came from what you would call the highest socioeconomic strata. So essentially, this was what we call a white suburban study. Now, as a part of the direct study, it was agreed nationally to translate it across the UK. And UK launched something called NHS Diabetes Remission Program. We had a pilot in Birmingham, and there have been pilots across. Now, the finding of these pilots has been published in Diabetes Care. And this basically looked at the incidence and characteristics of remission of type 2 diabetes in England. And what it showed is that nearly 2 million people with diabetes, the overall remission rate per 1,000 was 9.7. showing that it was only working in a very minuscule number of the population. But what was interesting is that if you actually go down and see that in people, the diabetes remission program was working were white ethnic female and with lower socioeconomic deprivation. So what this study is showing is that when you translate direct into a population level, it works, but it only works in the population in which the original study was done. And this is an important concept we all got to understand when we translate studies. So direct works, and it works brilliantly, but it works only in the population in which the original trial was done. Now let us look at a very good example about the study that works in all population, but it has been done in all population. This is the diabetes prevention program. So diabetes prevention program works, but we had the Dashing study, which was done in a Chinese population, the Finnish diabetes prevention program, which was done in the Finnish population, the diabetes prevention program done in the American population, and the Indian diabetes prevention program done in India. But what these studies actually show is that the way the diabetes prevention program works is different in different populations. And therefore, when you translate this into clinical practice, then different parameters should be used. So this is the diabetes prevention program and Finnish diabetes prevention program. Finnish was mainly in white European. DPP also was majorly in white Europeans. And what it showed was the lifestyle group actually works better than metformin in DPP. And the remission or the prevention of diabetes is close to about 50, 55, 58% in the lifestyle program. But if you look at the Indian diabetes prevention program, it shows that it works, but it works only in about 40% of the population, which is less. But interestingly, in the group that was given metformin is as effective as lifestyle. As if you look in DPP, metformin was much lower than the lifestyle. So what it shows is in an Indian population with prediabetes, metformin is perhaps as good as lifestyle. There could be a variety of reasons for that. It could be a different burden of disease, probably less beta cell, more beta cell dysfunction than insulin resistance, less obesity, and so on and so forth. So what I have illustrated here today is if you have a clinical trial program in a population, you can pick up the subtleties which are there in differences and then use in clinical practice. So what are the challenges? What are the challenges of achieving a representative global population in clinical trials? The biggest of it is funding. Now, when it comes to funding, most of the major funders of clinical trials, the MRC, the Wellcome, the Institute of Health in the United States, or NIC, these usually fund studies which are good, but it doesn't really look into the representative population. The second is, if you look at the industry, most of the industry now is much more focused on the Western Hemisphere. But as the things are changing, the pharmaceutical industry is realizing, and especially during the COVID times, especially with the vaccine programs, there was insistence by various governments that the studies should be done in the local populations. The second issue is study designs. When academics are designing studies, they're more looking for the results rather than the representative population. So this is something we need more adapted studies. Reviewers. If you look at reviewers, both in terms of publications as well as the funders, they again look at the quality of the studies rather than the representative populations. Recruitment has been an issue. And the reason for the recruitment being an issue, and there's been a lot of work that has been done by us and others, is that the methods that we've used for recruitment, especially in the Western countries, is more based on a white population rather than an ethnic minority or a South Asian or a Black population. But if we adapt our recruitment paths, as we have shown with the UCATs and other studies, it is possible very much to recruit an ethnic population. There are lots of issues around what we call the perceived barriers, and these perceived barriers are, and this is probably true at a global level, that a lot of people in India and other countries and the UK somehow don't understand the importance of research and somehow have this conception that research may probably harm and they're being used as guinea pigs. But this is something that we all have to do to try and get rid of barriers. Language is an issue because most of these clinical trials are done in English and they're translated in English, so it's much more easier to recruit a kind of an English-speaking population. So the question now is that what we are talking about is not inclusion, but proportional representation. If type 2 diabetes, as in the UK and as in other countries, is 6 times more common in a South Asian population than a white population, then the South Asian population should be more representative in this study. And finally, we need good quality academic interest by academics globally to push for a representative population diabetic things. So these are some of the recommendations that I have made, and this is for the UK, but could be used globally. Is the first thing is that all clinical trials, this includes the pharmaceutical major outcome trials, should have ethnic coding. If you look some of the studies that have been done with the glucose lowering therapies in type 2 diabetes, the ethnic coding is not very good. They use the word Asian, that includes right from Japanese, Chinese to Malaya, to Indians, to Pakistanis, to Arabs. That is not right. We need a much more better ethnic coding in research. The second important thing, and this is something that we're pushing in the UK, and I urge my Indian colleagues to push it with the government of India as well, is that there should be a legal framework for representative population. The Japanese do this, that if the research study does not have a representative population for a therapy or for a technology, then it is not licensed. This single change will force the pharmaceutical industry to have a more inclusive, representative population. And this is what we are trying to do in the UK. The other thing is when funders are giving it, there should be a thing of doing what I call impact assessment of research on the whole population. Should be a mandatory requisite. It cannot be on a group of population if it shows, but it should be in the whole representative population. We need a culturally competent language training for researchers, and this is true globally, where they can explain to their patients what is research, why is research done, and the importance of research. And finally, when it comes to funding, and this is more for the NHS, there should be schemes to be based on equitable outcomes in all populations. And this is my final slide in what I call equality versus equity debate. So thank you very much.